Welcome to Innovations in Sharps Management. I will talk a little bit about safety and the use of handling scalpels, needles, and a variety of other areas that hopefully you'll find interesting. My name is Allan Brack. I work for ClickSmart as an educator. So I travel around the country offering free courses on both sharp safety as well as OSHA. If you have any questions along those lines or you wish to have somebody come to your facility for a talk, feel free to write me at hello@clicksmart.com. This particular webinar is geared towards surgical technologists and is very similar to the one given to nurses, but with more of an AST bent to it. What we're going to try to cover is identify risks and impacts associated with sharps injuries, understand the incidence of those injuries and the statistics that will illustrate just how dangerous a place is that you work in. And we'll talk about why staff members ignore their own personal safety. We'll discuss regulatory issues, guidelines, and some of the updates that you may not be aware of. I'll talk about the concept of costs and benefits of scalpel safety, ampule safety to a lesser degree, and needle safety. And hopefully we'll cover some areas to how to improve safety into the workplace. But what's the worst thing that can happen to you from a sharps injury? Death is not an exaggeration, believe it or not. The following four people all served in the medical area one time or another. They are all no longer with us. These people were sharps activists, so they were extremely interested in sharp safety and unfortunately passed away from sharps injuries acquired in the hospital, whether hepatitis C, HIV, or a combination of both. So hospitals are dangerous places, and when I get to OSHA, I'll talk a little bit more about just how dangerous they really is. So 70% of sharp injuries go unreported. That's not particularly new. I'm sure you've heard that statistic before. There's a variety of reasons for it. We'll discuss them, but not the least of which is people just feel silly if they cut themselves or they get a needle stick, typically because they were rushed or they had to do something quickly. They didn't stop. They continued to work, knowing that if they followed the hospital protocol, they were going to have to go to the ER, they were going to have to have blood drawn. Who knows how long it would take to do that, since it was such a minor injury. The ER normally would triage their patients first prior to dealing with a simple needle stick. But 3 months later, you'd have blood drawn again. A year later, you'd have blood drawn again. If you're aware of that, then you're also aware of how easy it is to just pretend it didn't happen. Sweat bullets for a few months and then hopefully forget about it and nothing happens. But 40% of the injuries occur after the use of the device, meaning that the devices are contaminated, whether it's needles or it's a scalpel blade, and that makes it very dangerous. So nurses and techs really account for about over 40% of the injuries that are reported in the hospital. Fuentes did a study a number of years ago that took 137 patients or 137 users and then compared who was the most likely to be cut and or have a stick. Obviously, surgeons in the OR were number one in terms of medical professionals, but that's in the field. But nurses and surgical techs were extremely high as a percentage, and we'll talk about that as we go along. 7 to 11% of all injuries are scalpel blade injuries. If you are loading a scalpel blade onto a handle and you cut yourself, then obviously it's your pathogens, and the likelihood of you coming down with anything other than a painful cut is relatively low. However, if it's post-use, then it's relatively high. If you look at the total number of needle sticks and or scalpel blade cuts in a year, for every 100,000 blades, there are 660 cuts. For every 100,000 disposable syringes with loose needles, there's 3.2 per 100,000. Now that is the universe, meaning people that use scalpels could be anywhere from someone cutting a piece of balsa that's a hobbyist to the OR. In the actual OR in the US, the published data shows that it's somewhere between 12 and 15,000 cuts per annum, which means that if you look at the number of hospitals that are out there, it's anywhere from 2 to 3 scalpel blade cuts per hospital, which is a very high number. What are your chances of getting one of these infections from a scalpel injury? Well, for HIV, relatively low. Typically on a used blade, there's not enough of blood to carry a significant viral load that would cause you to acquire HIV. Hepatitis B, you should be vaccinated. In theory, that should never be an issue, but hepatitis C is a very real issue. And I've had a number of nurses and or techs tell me, well, you know, my chances are really pretty small, and hepatitis C just is not something I worry about at the hospital. Tests every patient before they get into the OR. And of course, those tests are only valid in theory on the day it happened. But if the viral load isn't high enough as yet, hasn't built up high enough into the patient, your chances of getting it are still very real. There are 17,000 new cases a year of hepatitis C. That's a lot of people. If you look at the expense, it's huge. If you spontaneously clear, that's 20 to 25% of the patients. 75 to 80%, however, will develop chronic Hep C. 5 to 10% of those will go on to develop cirrhosis of the liver with subsequent liver failure, lung cancer, and death. So hepatitis C is a very, very serious problem in the OR, and it's something that you have to be aware of. Now, is it possible to cure? When I started giving these talks 5-6 years ago, there was not a cure available. Now there is. They're known as direct-acting antiviral agents. They treat upwards of 6 virus genotypes. So in theory, you can get rid of it. In practice, the cost is anywhere from $80,000 to $95,000 for a 12-week course. If you wanted to treat all the patients in the US over a 5-year period of time, you would have to spend between $136 and $190 billion. Obviously, that isn't going to happen. So there's a lot of potential time bombs walking around that put you at serious risk dealing with these patients. The side effects of the cure are fevers, chills, muscle aches, nausea, vomiting, and on, including depression and anxiety. Those side effects should remind you of what people go through when they're on chemotherapy. It is not a pleasant experience. And of course, societal issues. Is society willing to treat everybody as opposed to not treating? And certainly, there is no way anybody's going to go out on a major effort like polio or some of the others to get rid of hepatitis C. The cost is just too high. So every patient that comes into your OR is a potential disaster for you if you're not paying attention. I won't spend a lot of time on ampoule injuries, but A significant number of injuries in the OR created from ampules. Typically, glass ampules are more or less on the way out. Anesthesia does use them, and they use them typically for fentanyl, or endoscopy will use them as well. 54% of anesthesia personnel have experienced ampule injuries, and I am one of them. I can remember being at an AORN meeting a number of years ago in Anaheim, where I was demonstrating with gauze how to pop the top off of an ampule. It shattered in my hand, large cut in my thumb. I had 10 nurses standing there competing for who could hold my hand and staunch the blood flow quickly while I had blood all over the table in front of me. They are dangerous. There's a number of ways to avoid being cut, and there are suggestions that you can make to people that work around you to avoid having ampule injuries occur. 30% are nurses, and the rest, of course, will be the anesthesiologists and/or endoscopists. So what's the least worst thing? I hate that term, least worst thing that can happen to you from a Sharps injury. Well, for one, there's the cost, and the cost in the hospital can be anywhere from $2,000 to $5,000, depending upon where you are in the United States. If you're on the East Coast, it might be closer to $5,000. If you're in the central part of the US, it's probably closer to $2,000, and then it goes back up again as you go out to the West Coast. And that cost is typically the tip of the iceberg, because what you're seeing is the cost to actually get down to the lab, have blood drawn, 3 months later having it drawn again, a year later having it drawn one more time in an effort to make sure that you're actually free of any of the potential diseases that you could have picked up off of a needle stick or off of a scalpel blade cut or suture needle for that matter. Then, of course, the fun part, no sexual intimacy for a 3 months period of time at least until you've been cleared. Now, when I give these talks live at individual hospitals, invariably I'll suggest that if you're over 50, you'll go yay team, which always gets a laugh. If you're under 50, then it becomes a major issue when you have to go home and explain to your significant other that there is a possibility that you could have acquired a bloodborne pathogen issue of one type or another from a cut, and that you have to be extremely careful going forward until you've been cleared. That is not a pleasant conversation to have under any set of circumstances. And of course, if your hand is in the field, and if you're a surgeon, whatever, or a tech, and you do cut yourself, if there's any nerve damage, artery damage, et cetera, then it could become a very expensive proposition that hopefully the hospital will pay for. And what's important is reporting. And if you haven't reported, it's very easy for the hospital to say some 3-6 months later when you come back and say, I've acquired HIV or hepatitis C or both, and it occurred in the OR under such and such a date when I cut myself. The hospital say there's no record of you having done that. And because there's no record, you run the serious risk of being considered living a promiscuous lifestyle, and the hospital will not have to pay for any services that you may require. That is a huge potential economic burden, and something that you should be very much aware of when you're working in the OR. So what can happen to you? Obviously, loss of individual productivity and income. Depending upon the hospital, some hospitals will not allow you to work in the OR post-cut and or needle stick because they're concerned that you might be then a carrier. Other hospitals will allow you to continue to work, and I know of at least 3 where the operating room supervisors have HIV and hepatitis C and continue to work on a regular basis. Now, obviously, there's a lot of distress that can be caused by a uncomplicated injury. There was a paper done a number of years ago in one of the nursing journals that talked at length about the equivalency of a needle stick and or cut to a major car crash in terms of post-traumatic stress disorders. For those of you that have been cut or had needle sticks, you probably recall vividly what you went through as you literally sweat bullets thinking about this. And then obviously the effect on relationships, self-blame, interpersonal relationships suffer. The self-blame is fascinating. There was a nurse that accidentally was cut in the OR, and one of the other nurses said, Mary, what have you done? And of course the question shouldn't be what have you done, but what do we need to change to make the environment safer? A hospital can mandate safety, but unless you practice it, it becomes meaningless. So whose responsibility? I am from the CEO on down, and you look at all the different people that potentially can affect safety to one degree or another. Everyone has to participate in it. It can't be just a single person. And that means culture has to change. The culture in a hospital has to go from 100% all we worry about is the patient to 100% we worry about the patient and staff equally. You cannot have a safe environment if only one side of that equation is being looked at. Well, let's look a little bit about regulatory. What's really going on in the regulatory world, and how can that affect you as, in theory, a user? The bloodborne pathogen standards were published started in '87, and have been updated every few years subsequently to the initial act. But some of the must requirements that you have to be aware of is you are required to select safer devices for use in the OR. And by required to select safer devices, you have to participate as a tech, as a nurse, as anybody in the OR in the decision-making process, and that must be documented. In other words, a hospital, an administrator, a manager can't mandate something unless you as a user participated in the changeover to a new device. That has to be logged. Those logs become incredibly important because they have to involve you, but they have to identify all the devices that you use, and these have to be ongoing. So periodically, you have to open up your logs, look at new devices that are available that in theory would keep you safer than existing devices, and you must maintain a log for that. I'll talk about fines for failure of maintaining those logs later in this talk. So one of the big excuses that surgeons can use to get out of using safety scalpels, which some years ago were mandated by OSHA for use in all ORs, is that if the use of a particular engineering control, in this case a safety scalpel, compromised patient safety, its use would be considered not feasible. Meaning, a surgeon can say, I hate safety scalpels, and I hate them because they're slippery when wet. They compromise my ability to view geography as I'm making my cuts. They're difficult to use, bulky, et cetera, and I don't get the tactile response that I get off of a metal handle. All legitimate. When a surgeon says that, you must document it. If he's not going to use safety scalpels, you must have it in your logs that this is why we do not use them. And this is the criteria that we use to determine that they can't be used. As long as you're using a single-handed blade removal system and or a single-handed needle removal system, then you're okay. But the minute that you begin to use things like needle drivers, Kelly grips, any device that you use to pop a blade off or to pull a needle off, if you're using both hands, one holding the device, the other hand holding the item you're trying to separate, you are contravening the law. And that can be incredibly expensive beyond the fact that it's incredibly dangerous. It's hard to believe that a single blade in your hand with a needle driver could be dangerous. I mean, in theory, you've done it a million times. You know how to do it. There's no magic to it. You just pop it off. Of course, we know that all blades come with pilot's licenses and fly around the room. And now you're looking for tape to pick them up off the floor, or they break, and now you're trying to figure out how to get the end piece off. That's the broken part. The minute you use two hands, you run the risk of hurting yourself, and that is why OSHA demands that you use single-handed systems to remove blades and or needles. Hemostats have been used as a measure in the past, and you're expected to use something safer. And for a long time, the suggestion was using a single-handed mechanical device to remove a blade and or a needle. The reality is now that that has become the standard. And as soon as something is a standard, if you get hurt and there's an inspection and it becomes obvious how you were hurt, the hospital's liability goes up at a great rate of knots. So you have to be extremely aware, and your hospital has to be aware of the tools they give you to help you stay safe. You can't use fingers. And obviously, 10 years ago, everybody used fingers to one degree or another. Certainly, a lot of techs have told me that that's how they were taught to take them off. That changed a little bit in that they went to forceps or Kellys or whatever to pop them off. You can't use resheathing, meaning anything with two hands. And it should be obvious looking at these pictures that if you're resheathing, you're using two hands. People talk about scooping needles off the table. They drop the cap onto a table and then they scoop it closed. In theory, that's okay. In practice, it never works as well as it should. And your chances of cutting yourself and or having a needle stick go up commensurately. AST itself came out with a revised standard in 2017, and this is taken directly from your AST manual. It's been updated since 2006, most recently April 14th, 2017, where if a safety scalpel is not used, the recommendation is to use a single-handed blade remover and a neutral zone. And that has been shown to reduce injuries. One study found that using a single-handed blade removal with a neutral zone was up to 5 times safer than a safety scalpel. And the recent 2018 EpiNet listing of injuries confirmed that yet again. OSHA telling you that you should use a single-handed blade removal is obvious. But the real issue to me there is, why would you want to run the risk of cutting yourself regardless of how competent you are in pulling blades off with Kelly grips or forceps? If you think it through, when you're using two hands, it's very simple for somebody to distract you, call your name, or you're rushed and you find yourself in the position of doing something that potentially is silly, and you end up cutting and or sticking yourself, which is something that is totally unnecessary and should be avoided at all costs. If the AST has published this as part of their standard and OSHA has a rule for it, the hospital liability goes way up if they do not supply you with a safety device that allows you to pull things off single-handedly. Blades and or needles. Beyond the fact that you're contravening your own organization's basic rules, which tells you that you should be using a safer method of being able to remove these sharp items from the syringe and or a scalpel handle. Poor results on staff safety. And we talk about the elephant in the room. The elephant in the room to me is always the hospital thinks in terms of patient safety. Everything is geared toward patient safety. However, what's missing is staff safety. You cannot have a safe environment if you're only looking at the patient. You must look at both sides of the equation. If you aren't keeping yourself safe, then that becomes a major potential issue for both the hospital, the economies of the hospital, as well as your own health. And it's something that should be avoided. Safety can be mandated by a hospital, but it can only be practiced by you. And you can't help your patients if you can't work because of a bloodborne pathogen issue that you were involved in. We look at unnecessary self-sacrifice. If you think safe, you'll be safe, hopefully. People will always work on the assumption that if I do more for my patient, for example, a patient falls off a bed, a nurse will typically go and try to lift them up and get them back onto the bed. And if they weigh 100 pounds and the patient weighs 250, there are obviously going to be some back injuries. And that really is the number one problem in a hospital is back injuries followed by workplace violence, followed by sharps injuries. And it's interesting that over the last years, there was a 31% reduction in sharps injuries across the board in the hospital, with the exception of the OR, where there was a 6.5% increase in injuries. I suspect that increase in injuries is caused by people trying to move too quickly, by ORs having to turn over too quickly, because obviously the hospital and the doctor can't make any money if the OR is just down for whatever reason. So there's always the pressure to turn it quick and get the next patient in and start the next procedure. You must do it in a safe manner. We all think we're bulletproof, invisible. It's a little bit like looking at the teenager. You give him a car key and he thinks he can do anything, drive at any speed, and nothing is ever going to happen to him, where in reality, it will and does, which is why we have 12 to 15,000 cuts per annum in the American hospital system. And every person that I've ever given those statistics to will always look at you and say, well, it's never happened to me. And I can almost set my watch that within the next year or two, something is going to happen to them, because those are the people that don't pay attention and believe they're bulletproof. Self-blame, yeah, my fault, deserve to be punished. And that really goes back to when you cut yourself or have a needle stick or a suture needle thing, you will always think in terms, well, it was my fault. And by my fault, I moved too quickly. I wasn't paying attention the way I should have been. I've let the team down. In the perfect environment, there should be no fault. Fault is a ridiculous term if you think about it in an unsafe environment. What you have to look for are systems that allow you to keep yourself and your patient safe equally. And if you don't get anything else from this talk, that is something you have to think in terms of cultural change. Nobody likes to do something new or something different to what you've been doing for the last 30 odd years if you've been around long enough. The reality of it is injuries occur every day. They occur across the board, whether you're a newbie or you're an experienced tech. And they're, in most cases, avoidable if you get into the mindset of safety is important. This is not to denigrate management, but if the typical manager will look at a patient through glasses, as you can see in this cartoon, but they don't see the staff on the side. That type of culture really has to change. One of the things OSHA tries to do is force and push for a safer environment in the workplace to protect you. It's not about just creating fines, but they are interested in being able to create an environment where safety becomes the principal activity of all concerned. Does it cost anything? You know it does. There are a variety of devices that will allow you to pull blades off and or needles single-handedly, and that is an additional cost. What people forget is that in most hospitals, it's very hard to determine what those real costs are and what is hidden. And by hidden, anything from OSHA fines through to legal actions taken by staff because the hospital did not meet the minimum standard of protection for them. Those costs are very high beyond any of the blood tests, doc time, evaluation time, loss of work, on and on and on. It becomes kind of a major issue. If you look at what can be done, obviously education, action result in benefits. You know, the gentleman that coined the phrase evidence-based medicine really had an interesting comment once where he said that if you go to a trade show or take part in a webinar such as this and you learn 2 new things, then that was a very successful meeting that you attended. The downside is if you've learned the 2 new things and you do not put them into practice, you might as well not have gone because it then becomes pointless. So, audit action, not knowledge. Audit action is basically a way to be able to have the hospital look at their systems to ensure that they're offering you the safest possible environment, and there is an audit process that they can go through to prove it. If you look at hospital fees right now, or fines right now as opposed to fees, I can think of 3 different hospitals in the last couple of years that have had major fines. The first was a hospital in New Jersey that was actually a surgery center that was fined $55,000 for their blood-borne pathogen standard, their failure to meet the standards, and an inordinate number of needle sticks and scalpel blade cuts, a log system that was inadequate, that did not show what was changed or fixed, and then nothing to show that employees took part in the safety aspects that were required by the OSHA standard. $55,000 to a surgery center is huge. But another hospital in New York City, and a major one, was fined $200,000 for the same things. So this is becoming expensive. Years ago, it used to be that in places like Tennessee OSHA was very active in doing audits in hospitals, and the average fine was around $1,500 per incident. That number is now at least 10 times to 20 times higher. So this is something that you have to be aware of for your facility to ensure that in order to avoid unwanted costs, you should be looking at your systems on a regular basis and logging them. If you look at where injuries actually occur, 50% are preventable. This was Fuentes did a study back in 2008. I doubt much has changed. You can be caught loading or passing, and then certainly in use, which is the largest area. But then when you start going down to removing blades and or needles, disposable, cleaning, and then downstream, meaning get down to CNS when a blade and a handle somehow find themselves down there having escaped the OR, These are areas that at least the latter four we can avoid if we use some kind of a single-handed system. Now, what's the difference between active and passive? Passive safety is obviously superior safety, meaning that it's automatic. If you look at blades that automatically retract and are fully retracted, that would be considered passive. If you're looking at something where you manually have to do something using two hands, where you have to resheath or you have to push a scalpel or a needle cover up over the needles, then obviously that's active. Active safety is got to be inferior over passive. Passive safety is met when you're using single-handed systems to remove blades and or needles. So if you look at retractables that are automatically activated by a spring, it's obviously passive. And if you look one that are manual, that you have to physically do something, that would be active and would not be as safe, period. And these should be documented in your log system. So single-handed blade removals work. And it doesn't really matter whether you're using a flask, a large device that pulls off a significant number of blades, and or sterile devices that can be used in the sterile field that will allow you to reuse the handles but still pull blades off as you're going through a procedure. That being a passive device. And if you look at the safety scalpels and or regular handles where you have to physically do something with two hands, then that would be considered active safety and would certainly be statistically considered unsafe. And from your own practical experience, I'm sure you've seen them as being unsafe. And if you look at the actual activation rates, it's interesting. When I ask people that are using safety scalpels, how often do you see a handle in the nemesis ball or in the neutral zone that has not been fully retracted? They all smile. See, we see it all the time. The active safety requires you to actually physically pull something all the way back before you drop it into your neutral zone, and that by definition has to be unsafe. As you reach into a neutral zone to pull something out, to dispose of it or to put it somewhere else, whatever you're doing, if it has not been fully retracted and it's a scalpel blade and or a needle for that matter, then obviously it is inherently unsafe and your risk of being stuck and or cut goes up significantly. So if we look at where injury preventions can occur, obviously safety scalpels, 17% are activated, meaning that the bulk aren't. So some portion of the blade is still sticking out. That is a significant problem. The combination of a single-handed blade removal with a hands-free passive technique, meaning dropping it in a neutral zone, could have potentially prevented at least 61 injuries in this example. That makes it 5 times more dangerous to use safety scalpels than using a standard handle. So active safety devices such as the safety scalpels have a wide variable in terms of activation rates, and they can be anywhere between 17 and 90%. While a single-handed blade system will work 100% of the time. 90% of surgeons surveyed in 30 hospitals in the US and Australia dislike safety scalpels and for the reasons that we've discussed: light, cumbersome, slippery, and then not allowing you to be able to see geography as you cut. So you certainly don't want to become one of these victims of an occupational injury yourself. So you do have a choice. You can practice a safe environment just for your own good. But for the hospital, you can also practice in a safe environment if you stay aware of being able to remove things with a single-handed technique rather than using both. Of course, the question is, what's your life worth to you? And how much does your hospital think your life is worth to them? Very real questions. And when people tell me that the cost of using devices to remove a blade are too high, these are devices that cost less than $2. It's almost laughable when you consider the real cost that hospitals face and pay daily without really thinking about it. There's just no justification for not using single-handed devices and for not keeping a safe environment for everybody in the OR. The only reason I show this is I love the cartoon. The guy standing with his scalpel blade stuck straight up in the air. That's got to be a little bit concerning. And then certainly going to surgery.com to click on "Are you totally lost?" is probably not a good idea. So if you want to use a non-sterile scalpel blade removal, there are available. This particular one from ClickSmart will allow you to meet the regulatory requirement of single-handed blade removal. You can hang it on a wall or on a table. They work extremely well. You get a clicking sound to give you an audible message that the blade has been removed, and you can take up to 100 blades off with that particular box. It also can be, it's its own sharps container, so it can be thrown in the red bag for disposal. The disposable devices that are available are sterile, and the idea here is to be able to drop them onto your table so that if you need to reuse handles and you want to pull blades off, there are a variety of devices that will allow you to do that safely and meeting the OSHA standard. So it's really time to become an advocate for safety. Safety is not a democracy. It is a human right. But the hospital can mandate it. Only you can practice it. Thanks very much for taking part in this seminar. Hopefully you've gotten something out of it. Remember, report if you do have a needle stick and or a cut. And remember that a single-handed device is what is likely to keep you safe from sharp injuries, period. Thank you very much for paying attention. I look forward to the next talk, which will undoubtedly be on OSHA sometime in the near future.